Hi guys, my name is Allison, and today I'm going to be going over the normal development of the heart, and then abnormalities of laterality, cardiac looping, and other heart defects. So we're going to start off with a brief introduction. Today we're going to be going over the normal heart development, including key cell types, establishment of laterality, heart tube formation, cardiac looping, septal formation, and then endocardial cushions. Then we're going to move on to congenital heart defects and other abnormalities, including their causes, presentations, and prevalence. After that, we'll wrap it up with how this relates to the PA profession. So there are two main groups of heart progenitor cells. The first travel through the cranial primitive streak and form the primary heart field, or the PHF. We can see along the top here that these red spots are where the first group has traveled up and settled along the edge to form the PHF. And this area will eventually become the atria, both left and right, the left ventricle, and then part of the right ventricle. The second group of cells travel to the posterior pharynx area and form the secondary heart field, or SHF. And this will eventually become the left ventricle, both outflow tracts, and the atria and sinus venosus. Patterning of cells that will eventually end up in the left or right sides of the heart follow the same laterality signaling cascade. Cells in the secondary heart field also contribute to the laterality. Cells on the right side of the heart will end up forming the left blood outflow tract, and then those on the left side of the heart will contribute to the right blood outflow tract. And then this is what explains the spiraling of the great vessels that we see in a normally developed heart. Laterality is determined by a signaling cascade involving serotonin, or 5-HT, which is concentrated to the left side of the embryo. 5-HT will signal through MAD3, which is a transcription factor that's actually not pictured here. But it will basically restrict nodal expression, which causes the expression of PITX2, and this is the master gene for left-sidedness. So if PITX2 is expressed, you will see a left-sided heart, or a heart that lies on the left side. So on to formation of the heart tube. The endoderm will induce the primary heart field to form myoblasts and blood islands. Major heart vessels are developing at the same time as all of this, and they will eventually become the outflow and inflow tracts of the heart. Embryonic folding is definitely an important part of this process. The folding pushes against the endocardial tubes and they fuse to become the primitive heart tube. The tube is first suspended by the dorsal mesocardium, and eventually the blood vessels will begin to form and provide support for the heart tube. So that's what's shown in this picture here. You can see the dorsal mesocardium kind of suspending and holding up the endocardial tube. So cells from that mesocardium will begin to expand over the myocardium of the tube, and the three layers that we know in a regular adult heart will form, so the endocardium, myocardium, and epicardium. In the secondary heart field also adds cells and elongates the tube. So once the cardiac tube forms, it will begin to loop around day 23. The cephalic end will bend ventrally caudally into the right, and this is how the ventricles are formed. The caudal end will bend dorsocranially into the left, so this is how the atria are formed. And if we think about the normal configuration of a heart, then this makes sense because the atria are, at least the left atrium is posteriorly on the diaphragmatic surface of a heart. The genes involved in this include NKX2-5, which is the master gene for heart development that comes from the cranial portion of the endoderm. A combination of secretion of bone morphogenic proteins, or BMPs, from the endoderm and inhibition of WNT secreted by the neural tube will cause NKX2-5 to be expressed. So WNT must be inhibited for the master gene for heart development to be expressed. Sonic hedgehog, or SHH, helps to regulate the lengthening of the outflow tract done by the secondary heart field. And Notch also plays an important role in regulating migration and differentiation of neural crest cells that separate the outflow tract. And then, as we mentioned, before PITX2 is the laterality gene that aids in cardiac looping. So next we're going to talk a little bit about the endocardial cushions, which is essentially what forms the septum or the septa of the heart. They divide the atrioventricular or AV canal into left and right parts, which is kind of what we can see at the bottom here. And they help form the membranous portion of the interventricular septum and then aid in the closure of the ostium premium, which we will see on the next slide. So the cushion region itself has the appearance of a cross with the AV septum forming the post and the cushions themselves extending across. So we can see down here, they will continue to extend towards the middle until they meet each other, which is kind of what's happening here. And then we have 4 endocardial cushions total, 2 lateral. Here are the lateral. And then 1 dorsal and then 1 ventral, which is what we see. And they will form the bicuspid and tricuspid valves. So the 4th week of development is critical for the fetus because that's when the atrial septum begins to form. The septum primum begins to grow from the roof of the common atrium down toward the endocardial cushion that separates the atria and the ventricles. A lumen is left by the first septum or septum primum, and this is called the ostium primum. So the first hole left by the first septum is the ostium primum, which allows for communication between the atria. Once the septum primum makes contact with the endocardial cushions, so once it physically touches the cushions, it will begin to degenerate. The first septum will begin to degenerate and the ostum secundum is formed. So the second septum or the septum secundum forms, but a hole is still present, which is called the oval foramens or the foramen ovalis, which is what we know commonly and is what's present even after birth. So the foramen will remain completely open until birth, but when birth happens, increased pressure from the left atrium pushes the 2 septa closed, creating the fossa ovalis. And this hole or the foramen ovale doesn't close permanently until about 2 years of age in 80% of people. And then of course it not closing is associated with the patency defect. So now onto heart defects. It's important to understand why things can go wrong. Many abnormalities are multifactorial, meaning that there are genetic predispositions as well as environmental factors influencing development. Teratogens are hugely important. They are basically any agent that can affect an unborn fetus, and they play a major factor in congenital heart defects. Common ones include rubella virus, SSRIs taken by the mother, alcohol consumption, diabetes, but there are many more predisposing conditions. They will affect the primary and secondary heart fields, the neural crest cells, and the endocardial cushions. Another important thing to note is that these defects are heterogeneous, meaning that one defect can be caused by several different cellular or genetic abnormalities. For a quick overview of congenital heart defects, so environmental stressors, as we previously saw, lead to many defects, but they are especially detrimental within the first trimester of pregnancy. There's a lot of things happening. A lot of the time, the mother doesn't know she's pregnant, so she's not taking certain precautions, and it's just all around an extremely susceptible time for the fetus to develop heart defects. They are the most common birth defects, with an incidence of 1% out of every live births. Congenital heart defects are. GATA4, TBX5, and NK2-5 are the 3 extremely important transcription factors that are commonly mutated in infants with septal defects specifically. Most CHDs fall into one of 3 categories: left to right shunts, right to left shunts, or obstructions. And the most common genetic abnormality causing CHD is trisomy 21, but there is many more that are related, and there's still a lot of research being done. So first we have hypertrophic cardiomyopathy, which is an autosomal dominant disorder with an incidence of 1 out of every 500 people affected. Mutation in genes encoding sarcomere proteins cause hypertrophic cardiomyopathy, and this is thought to be from defective energy transfer from mitochondria, so the energy producers of the cell, from mitochondria to sarcomeres. Most of the mutations are missense, meaning that a single nucleotide is changed, which results in the altering of the amino acid that will be encoded. Common mutations here are the MYH7 and the MYBPC3 genes. These are the common affiliations, but there are many more. Hypertrophic cardiomyopathy is characterized by massive myocardial hypertrophy without ventricular dilation. So we see here that the heart from the outer surface looks like it almost could be a normal size, but on the cut surface, extremely thickened septum, walls, and the left free wall as well. Most commonly, you see an asymmetric septal hypertrophy, meaning that the ventricular septum is thicker than the left free wall. Here, it's a little bit, the septum itself is a little bit thicker, but the left free wall in this case is pretty thickened as well. The ventricular cavity may be depressed, which, yes, we can see here, smaller than it should be. And there's often fibrous plaque formation on the mitral valve, which is what the black arrow is pointing to. Patients with this condition tend to be asymptomatic, but sudden cardiac death can occur as well as other symptoms. So the sudden cardiac death is when you commonly hear about a really athletic person suddenly dropping dead. This is a famous presentation of hypertrophic cardiomyopathy. Histologically, we can see extreme myocyte expansion up to greater than 40 micrometers, which they are enlarged in this picture here. You can also see disorganization of the muscle cells as well. And there will be narrowing and fibrosis of the small intramural arteries, as well as interstitial fibrosis. So next we have ventricular inversion, which is also known as L or LAVO transposition of the great arteries. This is the less common type of transposition of the great arteries, or TGA. It is characterized by the left ventricle being on the right side and connecting to the right atrium through the mitral valve. So that's what we can see in this picture here. The pulmonary artery will exit and receive blood from the morphologic left ventricle, which is definitely abnormal. Conversely, the right ventricle is on the left side and connects to the left atrium through the tricuspid valve. The aorta will exit and receive blood from the right ventricle. So it differs from the more common type of transposition because blood will flow normally, in the sense that the pulmonary artery will receive deoxygenated blood for transfer to the lungs to be oxygenated, whereas the aorta receives oxygenated blood for transferring to the rest of the body. It's for this reason that ventricular inversion, specifically this type, is also called congenitally correct TGA. Since the blood flow is normal, there's no cyanosis seen, and this defect may go undetected even into adulthood. The causes are not quite known, but genetics definitely play a role. So dextrocardia is a well-known abnormality of cardiac looping. The heart lies on the right side of the thorax instead of on the left. So this defect occurs during gastrulation when the 3 germ layers are being formed, or in this case, during cardiac looping. Defects in 5-HT can cause dextrocardia, which, as we know, causes the expression of PITX2, the master gene for left-sidedness. So without that, the result is a right-sided heart. Mothers taking SSRIs put their children at major risk for developing this type of defect. And dextrocardia is usually not life-threatening in this case, a cardiac looping defect, but it can be associated with more serious disorders such as situs inversus, where the complete reversal of all organs takes place, which can be life-threatening. Atrial septal defects are considered to be left to right shunts, meaning oxygenated blood will enter the deoxygenated circulation. The most common ASD is the ostium secundum defect, present in every 6.4 out of 10,000 births, roughly. There is a 2-to-1 prevalence in females. Most of these defects are sporadic, and the cells targeted are those of the primary heart field. Malformation of the endocardial cushions also play a part. So the ostium secundum defect is characterized by a large opening connecting the two atria. The size of the opening depends on how much blood will be shunted from the left atrium to the right. The most common cause of this defect, there are actually two. The most common includes inadequate formation of the septum secundum, so the second septum that's formed, which is present in about 90% of the cases that you see. And it isn't usually associated with any other anomalies of the heart, so it tends to be the less serious form. In about 5% of cases, there is an excessive breakdown of the septum primo. This is more severe and often associated with ventricular septal defects or AV valve malformations. And that's what this picture is showing here. You can just see the hole, and that kind of connects the left atrium to the right atrium, which is obviously not normal. A more rare and serious form of an atrial septal defect is the common atrial defect, which comprises less than 1% of all CHDs. This is the complete absence of an atrial septum, and there will always be other heart anomalies present, like a cleft mitral valve, and there will also or maybe no interventricular communication. Patients often present with dyspnea, palpation, and cyanosis, depending on the severity of the atrial defect. Premature closing of the oval foramen, or the foraminal valve, involves closure of the oval foramen before birth, and this results in death pretty early on after the after the partum period. Due to the closure, a massive right atrial and ventricular hypertrophy event occurs. This is due to the backup of blood and the right circulation, so the entire left side of the heart will be very underdeveloped. Not a lot's known about this ailment, but the picture I have here shows actually hypoplastic left heart syndrome, which is what some hypothesize is the result of a premature closure of the foraminal valve. But there have been very few cases and nothing proving it. I just kind of wanted to include this because it shows what we were talking about, the extreme hypoplasia of the left side versus the very large dilation and hypertrophy of the right side circulation. Endocardial cushion defects result from failure of the cushions to fuse properly, causing a persistent AV canal. So we can see in figure C here. And they result in a septal defect. So the atrial and septal components will be separated by abnormal valve leaflets, and there will be a single atrioventricular canal. So that is what we see. That is what we see in figure C here. Figure B will show the normal development of both the tricuspid and mitral valve leaflets, where there is clear separation here. And then we see that there is no separation, and it's basically just one valve. And this will occur in 1 out of every 5,000 live births. And then here's also just another image of the persistent canal. Partial fusion of the endocardial cushions results in an incomplete closure of the atrial septum. which causes an ostium premium effect with a cleft in the tricuspid valve. So the IV septum will be complete and normal with this defect. And then once again, the associated genetic abnormality is trisomy 21, so it'll increase the risk of this CHD. So here is a presentation of ostium primum. We can see the atrial septal defect here. The effect that this has on a person will 100% depend on how severe it is. So if it's more severe, this tends to cause death very early on in life. If it's less, people have been known to survive into adulthood, but there can be later on issues of dyspnea, fatigue, and then arrhythmias. So this defect looks relatively small on this echo, but it depends on, of course, the angle that the echo is taken at and then everything else as well. So yeah, very variable presentation depending on the size of the defect to the septum. So tricuspid valve atresia is our last correlate and is considered a right to left shunt. It occurs as a result of unequal divisions of the atrioventricular canal, and the result is a complete occlusion of the tricuspid valve. So to compensate, the mitral valve is larger than normal, while the right ventricle is very underdeveloped, which is what this picture shows here. So an atrial tricuspid valve completely closes it off, and the right ventricle is just minuscule in size compared to this huge ventricle right here. This anomaly is always associated with defects in the ventricular septum, of course, separating these two. So that would be this right here. And then patency of the oval foramen, which is shown by the dotted arrow here, meaning that right heart blood can escape into the left side, the left atrium. And then, of course, again, as we see with so many of these defects, trisomy 21 is linked and puts the infants at greater risk. Exact causes aren't known, but it's almost certainly involved with genes ZFMP2 and NKX2-5, which, as we know, is our master gene for heart development. So for the presentation of tricuspid valve atresia, we can see this more dense line here, which is the absent or the atretic tricuspid valve. So it's just solid, completely closed off. And then we see a ventricular septal defect here because here's the giant left ventricle and then the very small right ventricle. And with this, cyanosis will be present at birth, and then the mortality rate is high as well. So heart defects can relate to practicing PAs more than we realize. Of course, we're not going to see total heart transplants at the clinical bench every single day, but we might every once in a while, and it's important to be prepared for that. As we know, PAs are getting more and more involved in research every day, so that's always a possibility as well. You know, maybe working at a children's hospital in an area where congenital heart defects are common, you might find yourself involved in some sort of research that way. More commonly, valve replacements, as well as biopsies in vessels with the heart. And then in a forensic setting, it's important to note any heart defects, especially in young athletes, for example, with hypertrophic cardiomyopathy, as we mentioned earlier, those in children, and then trisomy 21 patients especially. These are all important to note because congenital heart defects are most of the time genetic. So if a child dies suddenly, for example, it would be extremely beneficial to let the family of that child, and especially the mother, know of any genetic predispositions she might be passing down in case she wants to try for another baby. Okay, These are my questions. And that is the end of my presentation. Thank you for watching.